Welcome to The Explainer. If you're prepping for your anesthesia finals, you're in the right place. We all know managing an airway in the ICU is a whole different ballgame than in the operating theater. Your patients are sicker, the environment is unpredictable, and the margin for error, well, it's pretty much zero. Today, we're going to break down exactly what you need to know to nail this critical challenge. So what's one of the highest risk things we do in the ICU? You guessed it, airway management. It's so much more than just putting a tube in. The environment's chaotic, the patient is often crashing, and the stakes couldn't be higher. Every single decision counts. Okay, let's dive in. Here's our game plan for today. We're going to start with the human element, our own brains, then walk through assessment, technique, what to do in the ultimate emergency, and we'll wrap it all up with an exam blueprint to bring it all home. First up, let's talk about the most unpredictable variable in any high-stakes situation: the human brain. Taming our own cognitive overload is every bit as important as knowing how to use a laryngoscope. And this right here, this is the core of the problem. When we're under huge amounts of pressure, our ability to think straight and follow steps just plummets. That's why having structured tools isn't just a nice to have, it's absolutely essential for keeping our patients safe. And this illustrates the idea perfectly. This is the vortex, and it's a really powerful cognitive aid. It gives you a crystal clear visual map for a failing airway. You've got your three main lifelines: face mask, a supraglottic, and the endotracheal tube. And you see how they all spiral down towards that final rescue, front of neck access. It's literally a mental map for when things get chaotic. The vortex isn't the only tool, though. For your exam, you should be ready to talk about a whole range of these aids. Things like the DAS intubation checklist, simple flowcharts, or even just having a purpose-built airway trolley that's laid out logically. They all do the same critical job. They offload that mental strain and build safety right into the process, so you're less likely to make a mistake when you can least afford one. So once we've got our own cognitive load under control, we can move on to the next crucial phase: assessing our patient and getting our gear ready. This is all about spotting trouble before it even begins. For your finals, you absolutely positively have to know the Makocha score. It is the only validated airway assessment tool made specifically for ICU patients. If that score is high, it's a huge red flag that you might be in for a difficult intubation. That's your cue to get experienced help and prepare your fancy kit. You really need to know these factors and their points. But let's be real, a lot of the time your patient is unconscious or uncooperative, and getting a Makocha score is just not going to happen. That's where this concept, the physiologically difficult airway, is so important. This isn't about anatomy anymore, it's all about physiology. You're looking for those big red flags: severe hypoxia, rock-bottom blood pressure, a bad acidosis. These patients have zero reserve. They are the ones who can have a cardiac arrest during induction, no matter how easy the view is. Now, before any tube goes anywhere near the patient, your number one job is preoxygenation. The goal is super simple: wash out all that nitrogen in the lungs and replace it with a reservoir of oxygen. This is what buys you that precious, safe apnea time. And you can do this with anything from a simple face mask all the way up to high-flow nasal cannula or even non-invasive ventilation. And please never forget the basics. Proper patient positioning seems simple, but it can dramatically increase your chance of getting the tube in on the first try. The goal is to get this classic sniffing position. You elevate the head, flex the lower neck, extend the upper neck, all to line up the airway axes. And here's your key landmark: the patient's ear hole should be level with their sternal notch. Okay, the patient has been assessed, positioned, and pre-oxygenated. Now it's time for the main event: actually securing the airway. Let's get into the tools and techniques. In the ICU, the standard of care is a modified rapid sequence intubation, or RSI. And that modified part is really key. It's our way of saying, hey, this patient is super sick, at high risk of aspiration, and probably hemodynamically unstable. So it means we're meticulous with our pre-oxygenation and positioning before we give a carefully chosen and often dose-reduced induction agent and a muscle relaxant to get that airway secured as fast and as safely as we can. This brings us to a really interesting debate: direct versus video laryngoscopy. Now, it's pretty clear that VL gives you a much better view of the vocal cords, but the high-quality evidence is still a bit murky on whether this actually leads to fewer complications. For your exam, the main takeaway is that you need to be skilled in both. It's also worth remembering that VL became the first-line recommendation during the COVID-19 pandemic, mainly to put a bit more distance between the operator and the patient's airway. Now, stop for a second. If you remember one number from this entire explainer, make it this one: 77%. A staggering 77% of ICU deaths from a tube in the esophagus, which was found in the huge NAP4 report, were linked to not using capnography. The message here is simple, and it's non-negotiable. Waveform capnography is the mandatory gold standard for confirming tube placement. Every single time. So we've gone over the plan, the backup plan, all the tools, but what happens when you've tried everything and you just cannot get the airway? This is the ultimate airway emergency. CICO. Can't intubate, can't oxygenate. These are the 4 words we all train for, but hope we never, ever have to say. It's that critical point where you failed to pass a tube, and you can no longer get oxygen in with a mask or a supraglottic device. Those cognitive aids we talked about earlier, they are designed to lead you to declare this. And once you do, you have to move immediately to a surgical airway. In a CICO crisis, the Difficult Airway Society guidelines point us to the scalpel bougie technique for front-of-neck access. You have to know these steps cold. Extend the neck, find your landmarks, make a horizontal stab incision right through the cricothyroid membrane, rotate the scalpel, pass the bougie, and then thread a size 6 tube over it. You need to practice this mentally and in simulations until it's automatic. All right, we have covered a ton of ground, so let's boil it all down into the most critical, high-yield points you can walk into your exam with. Think of this as your blueprint for success. Look, if you walk away remembering nothing else, remember these 4 things. 1. Master your human factors. Use cognitive aids. 2. Assess every single patient systematically, using tools like Makocha and always thinking about their physiology. 3. Always, and I mean always, confirm tube placement with capnography. And 4, have a rehearsed psycho plan and know exactly where your phona kit is. And this leaves us with a final question, one for you to take back to your own department. You know, it's one thing to know all the theory, but it's something else entirely to be truly ready when that moment arrives. Does your training, your equipment, your team, does it all give you the confidence you need to act decisively in that worst-case scenario? This entire deep dive was based on the really comprehensive 2023 article, Airway Management in the Intensive Care Unit by Edelman and Brewster. I'd highly recommend you check it out for even more detail. Good luck with all your revision.